Good afternoon, ladies and gentlemen. I am Hyeong-Gon Moon from the Seoul National University Hospital Breast Cancer Center. I will be talking about surveillance after treatment and screening of family members in breast cancer patients. Of course, getting cancer is not good news. It's very sad to hear that you have cancer. However, one thing that may give hope to patients is that breast cancer treatment outcome is much better than in many other countries. This graph shows the 5-year survival rate, and if you compare the major cancers that develop in Korean women, the latest data show that the 5-year survival rate in breast cancer is more than 90%, meaning that treatment outcome is better in breast cancer than in other cancers, which in turn means we have more survivors of breast cancer than other cancers. Now, breast cancer is the #1 cancer in Korean women, and we've seen a big increase in the number of breast cancer patients. So patients who have completed treatment, in other words, the breast cancer survivors, will follow up by visiting the hospital every year to get various tests. So I'd like to talk about the relevance of these tests today. First, let me talk about the screening of the family members. The key factor is to see whether the patient has hereditary breast cancer. In other words, is there family history of breast cancer and also genetic mutation with susceptibility to breast cancer? Then does everyone need to get tested for this? Not always. Let's say that you have breast cancer at a very young age, or if you're a male patient and you have breast cancer, or if you have bilateral breast cancer, or uh, if you have many breast cancer patients in your family, then we recommend genetic tests. Now, the genetic test results may show you may have mutation, you may not have mutation. If you do not have mutation, routine screening, like everybody else, is fine. But if you do have mutation, then your family members will also need to get additional tests. And if your genetic result tests shows that you have mutation, you will need additional workup, such as MRIs, in order to screen for breast cancer. That might be more helpful for the patient. Now, if the patient does not have mutation, then the family members will not have mutation naturally. But even if the patient does have mutation, half of the family members will not have mutation. So those without mutations may rest reassured because routine screening is okay. However, if there are many breast cancer patients in your family, then even without mutation, your risk for breast cancer may be elevated because of the genetic traits that we might not be aware of. So you should take care to get screening regularly. Now, what about the surveillance test for the patient herself? There are two purposes of such tests. First is to see if if there's a recurrence in new tissues, for example, around the tumor area or in the contralateral breast. This is called local recurrence. The second purpose of test is to see if you have metastasis. So metastasis is not recurrence in the peritumor area, but in distant areas, for example, lung, bone, liver, in other organs. So that is called metastasis. So there are two purposes in getting follow-up tests. One is for metastasis, the other is for local recurrence. So in the case of local recurrence, as you can see, you take the mammography for the breast and also monitor the surrounding areas. The specialists recommend getting at least one examination every year if you had partial mastectomy for both of your breasts. And if you had total mastectomy, then get x-rays and examination on your contralateral breast. If you have dense breast, you can have additional tests such as ultrasonography. Now, there is active study ongoing regarding MRI, but if you are at very high risk of local recurrence, then MRI might be helpful for you. Now, regarding testing for metastasis, I think I need to spend some time on this topic because the screening of the family members and local recurrence test was covered just with one slide because the conventional wisdom is not too different from the medical evidence. So it's very straightforward. However, the metastasis test is a little bit different because the general perception of the public is rather discrepant with the medical evidence based on studies. So I think I will need to spend more time on this topic. Let's say there's a 42-year-old female patient who was diagnosed with stage 1 breast cancer and is starting treatment. This patient is triple-negative breast cancer. In the case of triple-negative breast cancer, there's no long-term drug treatment or targeted treatment. So treatment is complete after the first few months. So the regimen will be surgery and then adjuvant chemotherapy, and after the adjuvant chemotherapy, you will get radiation therapy. That will be the general early treatment regimen. And after treatment, just like many patients, this patient will make regular follow-up visits to the hospital, see the doctor, get examined, ask questions, and so on, and also get referred to other specialties if necessary. But as you've all experienced, that's not all. Many patients follow up and get tested for various things. It depends on which hospital it is, but at SNU Hospital, we do offer quite a lot of tests to the patients. These tests will include more complicated CT scans or MRI scans or various blood tests in order to monitor the lung, the bone, or the peritoneum or other organs. So it varies by hospital, but all of these healthcare providers do offer a test for metastasis. Now, what can happen after the follow-up test are two things. So one outcome is being cured without any recurrence. Second type of outcome will be, which is very unfortunate, having recurrence of the tumor. So if the patient is cured, in other words, if there is no recurrence of the tumor and the patient stays healthy, all of these additional follow-up tests did not serve this patient at all. But if the patient had a crystal ball of some sort and can predict 100% that she will not have recurrence, then obviously this patient will not follow up because tests cost money, and also you need to invest time and effort to make those follow-up visits to get tested. Many patients in my outpatient clinic tell me that they lose sleep the night before the test results are out. So the anxiety is quite significant simply by being tested. And most of the tests use radiation, so there could be exposure to these radiation doses. But what is on the plus side, if the test results come out okay, then you can rest assured temporarily and your anxiety will be dissipated. So there's that mental benefit. But if you had known in advance that you'd be cured, you would never have had those tests in the first place. Now, the problem is about the recurrence patients. Will they enjoy any benefit by early detection of recurrence by tests? That's what I'll be talking about in detail today. Actually, even 20 years ago, we had a lot of clinical trials of that sort in breast cancer. So there was a trial that enrolled more than 1,000 breast cancer patients from various centers at the same time for a prospective, randomized clinical trial. Now, prospective means that we're going to follow up and look at the outcome in the future. And now randomization means that there is no intervention by the physicians in assigning the patients into two groups. They will be randomly assigned for the study. So randomly assigning patients to one of the two groups and comparing which group performs better in terms of outcome is the so-called RCT. Now, the randomization groups were as follows in this study. One group had only physical examination and breast X-ray. The other group had additional complicated tests for the bone, the lung, and the blood tests, in addition to the physician examination and breast X-ray, and they were followed up. So one group had tests for metastasis, and the other group, the one group did not have metastasis test, the other group had a full set of tests for metastasis, and the two groups were compared for outcome. Now, if you have regular intensive follow-up tests, then it is more likely that more recurrence is detected while the patient is still asymptomatic. In other words, you can detect the recurrence before the patient visits due to the development of symptoms. So in intensive follow-up group, the recurrence is diagnosed at the asymptomatic stage. In the control group, there were more patients who had recurrence detected because they visited the hospital due to symptoms of metastasis. So it is true that you can spot recurrence earlier, but what about the treatment outcome? Surprisingly, regardless of early or later detection of recurrence, the final survival period is the same. The two graphs are superimposed on top of one another. So what this means is that you can detect recurrence earlier, but that does not help patients live longer. In other words, early detection of recurrence did not translate into patient benefits. A similar study was conducted around the same time period in Italy. 1,000 plus women participated from 12 trial centers. And as you can see on the left-hand side, the intensive follow-up group is the black solid line. So it is clear from the study as well that intensive follow-up leads to earlier detection of recurrence. However, in this study, the survival period is the same between the two groups. So this study also demonstrated that there is no survival benefit for the patient even if there's more follow-up tests. So why is the treatment outcome the same when you detect the recurrence earlier? The biggest reason for this is after metastasis, in other words, the recurrence I've been referring to are all metastasis. So local recurrence, if detected early, can be removed completely. So it helps to detect local recurrence earlier, but metastasis is not something for which we can provide radical or curative therapy. So what we can do, or the purpose of treatment, is once there is metastasis, we try to delay the progression of the disease as much as possible and provide palliative care in order to help the patient suffer less. But regarding palliative care, there will ultimately come a time when the tumor can no longer be controlled. So if it's not radical therapy, then regardless of when you detect it, the outcome is similar. So if you have more intensive tests and you can detect it earlier, so that means you can receive palliative care for a longer period of time. And if that led to extended survival, that would be great, but that's not the case. So early detection before manifestation of symptoms makes it look like there is extended period in terms of time to death after recurrence. However, this simply shows reduced time to recurrence, and so it's an illusory effect because this part looks extended even though the overall survival is the same. So that's what these clinical studies show us. So we cannot help the patient live longer and healthier. Rather, on the contrary, with more tests, the patients are exposed to palliative care longer. So even if they are palliative, it does reduce the quality of life of the patient. So it will be like us going out of our way to identify these patients earlier before their symptoms are developed, only to reduce their quality of life during their survival period. Nonetheless, the reality is nationwide, hospitals, including ours, do perform such metastasis tests, and the main goal is to help the patient be assured, to tell them that they're not they don't have metastasis, so they don't have to worry. But the patients have this misperception that if they follow up intensively and regularly, then their treatment outcome will be better, meaning getting intensive follow-up tests may be helpful and may be helpful in treating the condition. So that is a misperception. So let's take a look at the recommendations of global guidelines. And the best known global treatment guidelines are the following: the NCCN guideline of the US and the ESMO guideline of Europe. Now, they both say that in the absence of clinical signs and symptoms suggestive of recurrent disease, then there is no indication for tests for metastasis, whether it be imaging or blood. Because there's no evidence yet that these intensive follow-ups provide benefit to the patients. These clinical data are very old, more than 20 years old, so I was expecting more recent data to be different. So we looked at our center's hospitals. About 400 patients were analyzed who developed metastasis after being treated since 2000. But even in recently treated patients, it did not show that there was any direct benefit to the patient. If they had more tests and had earlier detection, it did not lead to any extended overall survival or any other ways. So there are some other studies ongoing recently. Let me introduce one from our center. So this is supported by the Ministry of Health and Welfare, and it is our hospital that is the coordinating center. It is driven by the Korean Society of Breast Cancer's Survival Study Group, and many sites participate from Korea. Now, there are two parts to this study. So one is to create big data from various centers, because it varies by hospital and the consultation patterns may vary by doctor, and so we're collecting data to see whether intensive follow-up tests will lead to any beneficial outcome. Another part of this study is to see how the patients are receiving these kind of tests. So we provide sufficient training and education to the patients about the relevance of these follow-up tests via videos or brochures. And we ask the patients for their opinion, and we make shared decisions and then go for tests. And we are looking to see whether it helps with the patient's quality of life or mental health. So this is a prospective study. SNU Hospital, Borame Hospital, Samsung Medical Center. These three sites are participating. And in the retrospective, the second part, the cohort study, there are many other sites that are participating. I think we can tell you more once the data is out from these studies. I think we'll have the data published sometime around next year. Now, let me summarize my lecture. So it does help to get regular follow-up regarding recurrence around the tumor area or the surgical area. And as for screening of the family members, if the patient is not hereditary breast cancer, then routine screening is fine. Now, the metastasis test is different from the local recurrence test. It is not essential in principle if the patient is asymptomatic. And if the patient develops special symptoms without tests during follow-up, and then they can get tested for that area, that is sufficient. There are a lot of studies ongoing at the moment regarding the pros and cons of such metastasis tests, and we will have new data out. But many global treatment guidelines recommend that it does not provide any additional benefit to the patient, even if they're tested more. So the message I would like to deliver to you is as follows. Many patients ask me after surgery or chemo, what are the odds of me getting recurrence? Now, talking about such odds, between us, that is something that the investigators talk about over a certain patient population, because some will recur and others will not recur within the population. That's how we get certain percentage. However, in one individual, the likelihood is either 0% or 1%. You either have recurrence or do not have recurrence. There's no such thing as in between the two. And there's no way for us to predict the future. So you have to get treatment under the assumption that the recurrence likelihood is 0%. So thinking positively will help in getting your treatment. So the key takeaway message today is that contrary to what many people think, just because you get more tests for metastasis does not mean your treatment outcome will be better. Now, if you're getting hormone therapies or other therapies prescribed by your doctor, you should be compliant. I think that is the most important point in reducing the risk of recurrence. So you should try to have balanced diet and nutrition intake, and also work out at least once a week at high intensity. That will be helpful for you. Now, lastly, now you will think about breast cancer all the time, and you need to get rid of those ideas that come to your mind every time, because once you start thinking about it, you will never stop thinking about it. And even if you spend a lot of time thinking about it, it does not help with your treatment. So you should put on a positive and very optimistic mindset and try to think that your odds are 0% and try to enjoy life every day. That will be the biggest help, most helpful in treating your patient. Thank you very much for your attention.